the League of Women Voters, Northern Lower Michigan, our public forum on this fall evening. I'm Lisa Blanchard. I'm the first vice president of the League of Women Voters, Northern Lower Michigan. And I'd like to offer a few reminders before we start. Please be sure to remain on mute during the presentation. It's best to click on speaker view instead of gallery view, so you'll have a visual focus on each panelist as they present their topic. As usual, this presentation is being recorded. You probably got that signal. And it will be available on our YouTube channel, and the link is available on our webpage. Part of tonight's presentation will include a question and answer period. Please use the chat function to ask your question. We have a moderator who will read your question, and you can send them at any time, and someone will be tracking those questions and will read them to the panelists after they've done their presentations. And after tonight's forum presentation, we will have a brief member meeting. So I hope all of the league members will stay on after the public segment of the forum. For those of you who are unfamiliar with the League of Women Voters, we are a nonpartisan political organization that encourages informed participation in government. We work to increase understanding of major public policy issues and to influence public policy through education and advocacy. We do not support any political candidate or any political party. We do have positions on public policy which inform our advocacy work, and we have positions on healthcare. Mental health pertains entirely to a person's psychological state, while behavioral health entails not just a person's state of mind, but their physical condition. And of course, both are intertwined. Data trends indicate that mental and behavioral health issues in the US have been increasing, and services can be difficult to access. We are very pleased to have a local panel of experts to talk to us about mental and behavioral health issues in our area and the services available in our communities. Thank you to our healthcare committee for organizing this valuable public forum. And I'm turning the program over to Martha Lancaster from the healthcare committee, who will moderate our forum. Thank you, Martha.
Thank you, Lisa. As Lisa said, the healthcare committee put together this forum, invited the participants, and I'm just one of the members of that committee. The panelists collectively will have 45 minutes to speak. We've asked each one in advance to briefly tell us a little bit about what behavioral health services their organization provides and/or how it interfaces with other providers in the community. The League's Healthcare Committee has drafted some questions which we've provided to the panelists to give them some ideas of what we might want to know about. And as Lisa said, the final 15 minutes will be for questions from our audience, which we will pick up from the chat that you will type in. So I want to thank all of the panelists that are participating tonight. I'm going to tell you just a teeny bit about each one and then let them get started. Amy Christie is the Chief Clinical Officer for North Country Community Mental Health. She has been in that position since 2020, but she's been with the agency for 28 years, previously managed a variety of community-based and clinical services. She holds a master's in mental health counseling, a degree in business, and other certifications relevant to behavioral health, substance abuse, and leadership. Matthew Learstein is Emmett County Undersheriff, and he has been in that position for about a year. But prior to that, he served 5 years with the County Sheriff's Department as the Detective Sergeant. He started with them in 2006 and has served in a number of roles, including Road Patrol Deputy, Road Patrol Supervisor, and Undercover Narcotics. Timothy Cook is the Sheboygan County Sheriff. He was appointed sheriff in February of 2023. He's worked in law enforcement for 36 years, serving in roles also including road patrol, detective, and undersheriff. He has a bachelor's degree in criminal justice from Lake State and is a graduate of Northwestern University School of Police Staff and Command. Dr. Matthew McKenna is the medical director of the Justin A. Bora Behavioral Health Center at McLaren, Northern Michigan. He's a medical doctor specializing in general and child and adolescent psychiatry. He previously served patients for McLaren in emergency department, medical hospital, inpatient psych unit, and psychiatric partial hospital program settings. He attended the University at Buffalo School of Medicine and Biomedical Sciences, and he also completed his residency and fellowship there as well. So I will turn it over to Ms. Christie, who will have the first segment.
Thank you, Martha. I'm going to share my screen. And I'd like to say, whoops. Are you able to see the screen?
Yes.
Yes.
Okay. All right. Driving the technology struggle bus today a little bit. My name's Amy Christie, and I am the Chief Clinical Officer at Community Mental Health, North Country Community Mental Health. And I just want to give you an overview of the services that we provide and some of the initiatives and whatnot that we are moving towards in the future. So who is North Country? NCCMH serves Antrim, Charlevoix, Sheboygan, Emmett, Kalkaska, and Otsego counties. So we oversee the tip of the mitt, the northwest tip of the mitt. That is over 3,000 square miles. So we end up having an office in every county. We're primarily funded with Medicaid, Healthy Michigan, and general funds. And we're highly regulated by the Michigan Department of Health and Human Services. Our services range from infant mental health to older adult services and all age groups in between. As you can see from the chart on the right, with our revenues from fiscal year 2022, we have over $54 million worth of budget just from Medicaid and Healthy Michigan, showing that that is the primary population that we serve. Local dollars come from the 6 counties, and those are a set amount that was agreed upon between the counties and the CMHs, and that is $1.7 million. So who do we provide services to? We provide services to adults with serious persistent mental illness, children with mental illness, adults and children with IDD, which is intellectual and developmental disabilities, and persons with co-occurring mental illness and or IDD and or SUD, which is substance use disorders. You can see from the chart on the right that while the highest population we serve is the MI adult population, we should also know that the largest portion of our yearly fiscal budget is provided to the adult IDD population. And the reason being is that population has the highest needs, both behaviorally and physically and health-wise. So to be as independent as possible, most of those folks have a high budget for specialized residential care and care out in the community. So access and crisis services. Community mental health provides routine, urgent, and emergent access and screenings to anyone who presents with the need. It doesn't matter if you're a resident of the county or not a resident of the county that we provide services to. Our access line operates from 8:30 in the morning to 5 p.m. That is for the regular routine calls. And our crisis emergency line is 24/7, 365. We are always answering with master's level clinicians for our emergency line. The majority of emergency screens take place in 5 local EDs, emergency departments, because Antrim County does not have a hospital. So those folks typically go to another one of our counties or to Traverse City. Some of the emergency screens are completed in our local jails as requested by law enforcement, and some routine appointments end up in a triage. So someone might come in for the office for an access, and we might end up going to the emergency room because they're truly in crisis. Some of the services that we offer, as mentioned, we do crisis and emergency screens. We have two assertive community treatment teams. These are intensive, multidisciplinary teams that are out in the community, and each team serves 3 counties. We have case management for adult and children. We have outpatient therapy for adult and children, including individual therapy and group therapy. We have psychiatry for adult and children. We have board certified adult and child psychiatrists, as well as mid-level prescribers. So nurse practitioners and physician's assistants. We offer health services. We have clinic and community-based RNs, and we have a behavioral health home. While that sounds like it might be a home, it is actually a program that covers 6 counties, and it is for individuals with mental illness and physical comorbidities. So what it does is we have certified community health workers that work along with a nurse that develops a care plan and assists with getting people additional resources out in the community, making sure that they're taking care of their health as well as their mental health. We have specialty behavioral services. These are behavior plans, autism testing and services in the home, psychological testing for guardianships, and occupational therapy. These specialty services are typically authorized for individuals that are already open to our services, and we typically contract out with providers for most of those services. We have community-based programs. We have clubhouses. Clubhouses are psychosocial rehabilitation centers. We have 2, one in Petoskey and one in Rapid City. We run 2 specific day programs for individuals with IDD, but we also contract with other day programs such as Bergman Center, Straits Area Services, Crossroad Industries. And we have wraparound services offered through Northern Family Intervention Services. We have specialized residential services in and out of our service area. So to say that we only provide services in our 6 counties is probably a little bit of a fallacy, because we do have over 82 consumers that receive our services in other counties throughout the state of Michigan, all the way down to Wayne County. Special or self-determination services are, again, a service that are offered to any individuals that receive our services, and it puts the person in charge of their treatment plan and the services they're being provided. They're in charge of their budget, and they are the boss of the individuals that they hire to provide them support and services out in the community. And then we have infant mental health. This is a much more specialized service, and it is throughout our 6 counties, and it's working with families with infants or families or mothers that are expecting. So that is a highly regulated and a very small caseload type of service. So for every worker who is certified to do infant mental health, they can only have 10 cases on their caseload at one time. Telemedicine and telehealth. A lot of people have asked us about those services. And the MDHHS, the Department of Health and Human Services, does have very specific rules regarding the provision of these services to clients. They have to be by client request. The level of service needs to be at the same quality of a face-to-face appointment. The method of the service needs to be in their treatment plan if it's going to be ongoing remotely for a long-term basis. So if someone's going to wants to receive telehealth or telemedicine services, it has to be in their treatment plan if it's going to be a continued service. CMH does offer telemedicine with our prescribers. We do have physicians who also offer in-person appointments at our offices, but our mid-level providers are all via telemedicine. So our PAs and our nurse practitioners are all available through telemedicine. It gives us a stronger ability to be able to provide psychiatric services and oversight to 6 counties with only a limited number of prescribers. Our telehealth services can be provided in most instances, such as outpatient therapy and case management. We do have the expectation, though, if able, that face-to-face appointments are best practice. We like to be there. We like to be with the person and be able to see and experience the person as a whole. Community partners are our bread and butter. We can't do our job without our stakeholders and our community partners. We refer and partner with psychiatric units like the McLaren BHU. They just recently started accepting patients, and we've been calling them on a regular basis. I think Dr. McKenna probably has been experiencing that with us. Jail liaisons, we employ jail liaisons, and they serve 6 counties. They answer requests for consultation that typically come from the jail or the corrections officers, and they meet with inmates. We partner with community or the counties on stepping up jail diversion and specialty court initiatives and development. That is a grant offered through Wayne State University to be able to see what else we can do to provide services to individuals that don't necessarily need to be in the jail system, but need mental health treatment. Collaborative meetings with intermediate school districts. We have children's staff that go into the schools regularly to provide services for kids and staff in the school systems. We have active referrals to other agencies and providers, such as the Little Traverse Bay Band, private therapists, Women's Resource Center, DHHS, Housing Commission, Social Security, SUD providers, which are substance use providers, and primary care physicians around the counties. We have a variety of staff that participate on committees, community groups, community initiatives to support and strengthen behavioral health opportunities. So we do a lot of speaking engagements. Today, I had 4 different staff doing speaking engagements within the community. So we get out there and try to educate as much as possible. We also offer mental health trainings. Right now, we have 10 certified trainers in mental health first aid for youth and adults. We provide these trainings to community partners, agencies, groups, and individuals. We offer it either in person or virtually, and all people have to do is call us up and we schedule a training, and we go out there and provide that education to folks. Community mental health we've offered historically behavioral health emergency partnership training, which is a really intense training for law enforcement and EMS agencies through grant opportunities with the Cardinal Group. It's a 2 or 3 day training, and they do role playing and everything else. And it's a really great opportunity. And we're going to continue to try to offer it through this next fiscal year. We have clinic supervisors and jail liaisons that have been going and doing annual jail and law enforcement mental health updates. It doesn't necessarily meet the MCOLS requirements, but it does help with learning some of the new initiatives for working and intervening with folks with mental illness and developmental disabilities and autism. We have community presentations on a variety of topics. One of the biggest ones lately has been Carter Packs, Carter Kits, which have been going out in the community for EMS and fire department and law enforcement, and their packs for individuals who have autism to help them experience less trauma when something is when they've been in the middle of an incident. We have staff that are trained and certified in all 6 counties on critical incident stress management. When emergency management or local authorities call us, we go out and do crisis debriefing. And we've just recently done 2 in the last 2 weeks, one up in the northern Petoskey area and one over in the Otsego County area.
Excuse me, Amy, you've got 2 minutes left.
Okay, well, and here we go. So future opportunities for us, we want to continue advocating for local psychiatric beds for kids. There really aren't any, there's very few psychiatric facilities for children, and we don't have any in the northern Michigan area. Improve transportation resources, both locally and regionally, to aid our clients in accessing resources in their communities. We want to increase or try to help increase and advocate for increase of state psychiatric beds for both adults and youth. Currently, the wait list for clients to get into this intensive level of care is extremely long. I know that Sheriff Cook and other law enforcement and emergency doctors feel that, because wait lists can be anywhere from 20 to 200 people long to get into a state psychiatric facility. And then continue to strengthen our community collaboration with our partners and our community members. We want to increase the education that we provide regarding behavioral health services and initiatives. And we want to advocate statewide, as we are right now, as a rural behavioral health provider, because as we know, a lot of the regulations and initiatives come out of the southern part of the state, which is urban, and it doesn't always work the best in a rural area. So we try to be flexible with how to provide it and learn ways and try to influence the southern regulators as to how we can make it work up in the rural area.
Right. Well, thank you very much. We're going to now turn it over to our two law enforcement representatives, Sheriff Cook and Under Sheriff Learstein.
Good evening. Thank you for having me. I appreciate being here.
Matt, did you want me to go first on this?
I defer to you, sir.
Okay. Well, I am Sheriff Tim Cook with Sheboygan County. I thank you for the opportunity here tonight to speak with everybody. I think it's a very important topic. I think Lisa is absolutely correct, especially since COVID, what we're seeing in the communities with mental health issues. I'm going to talk a little bit tonight about mental health from a jail management perspective. And Under Sheriff Learstein will talk about how the road patrols deal with those that they come into contact that have some mental health issues. In our jail, it's not uncommon for me to have 50–60% of my inmates in my jail have some sort of a mental health issue. That doesn't mean crisis. That means some sort of an issue that they have that they need some care for. And that's where community mental health plays a big role with law enforcement. We utilize CMH services to come into our jail and offer their services through their employees, their staff, to provide consultation to our inmates. And many of that is done through an appointment. They are allowed to make an appointment with CMH, and their staff comes in and they talk with these individuals and work them through any mental health issues or situations they have. Not necessarily just being incarcerated, although that can be part of it. Many times it has to do with issues just from their home life or their upbringing that they just want somebody to talk to help them through this. So most of that stuff does get resolved through CMH. But when we have a crisis, it's a lot different. Our staff is trained to handle mental health crisis. They are trained to recognize and trained to take action to assist in mitigating that crisis. The way it usually works is if somebody in our jail has a mental health crisis, they will usually go to the emergency room, and the emergency staff will evaluate them and then bring in community mental health to assist in their evaluation. So you have a medical clearance, and then you have a evaluation by community mental health to see if that person can be cared for locally on some level, or maybe the crisis is severe enough that they're recommending that there needs to be a treatment, usually to a state hospital. So that's one type of mental health issue we have in our jail. The second type, or maybe now the third type, is when we have an attorney who is requesting a forensic examination on their client who is in jail. So that's a court process. There's a court order that's issued by the judge for that person to be evaluated to see if they understand the crime they committed and are they competent to stand trial. And so that order gets sent out, and then we wait until we have a confirmation of an appointment to handle that forensic evaluation. Amy is absolutely right when she talks about the need for beds. So if somebody is in need of treatment away from our jail, they're in jail, but they need treatment. It's not uncommon to wait 2 to 8 months for a person to get the treatment they need at a state hospital. So that person is in crisis, and our staff does what they can with the resources we have to tend to their needs. Keeping in mind that my staff are correction officers, they're not doctors, they're not psychiatrists. So we really work hard with CMH to try to keep them as calm and as stable as we can with the resources we have, including our medical staff that we do have here that we contract. Even on the forensic side of it, it can take 2 months before they're seen forensically to see if they can stand trial or are competent to stand trial. And if they're not, we're in the same situation. They then have to wait 2 to 8 months to get a bed at the state hospital. So that is a real issue with us. We can't take them to private places, to private hospitals or private care facilities. The issue with that is their staffing. Those private places have a hard time with control. And you have to remember, in a jail setting, we deal with very severe people. And so the private companies, they don't want us to bring them, the inmates to them as their patients, because they don't have the staff for security and control. So that's why we go to the state hospitals. So it's very tenuous on my staff, and it's very tenuous. It's very hard on those that are in crisis. I have a 103 bed facility. I probably average 75 inmates a day is my average. And I would say at any time I have 1 to 5 people in crisis. So that means that I have somebody in my jail today that needs to go to a hospital that can't. As much as we try calling, and as much as we try to say we have a situation that we feel is an emergency, you are on a waiting list. And Amy had discussed that waiting list can be up to 200 people. So that is a big issue for us. She also talked a little bit about the Stepping Up initiative that we're involved with. Now, I don't know if many of you have heard of the Stepping Up initiative. The state of Michigan recognizes that there's an issue with mental health, and they have granted Wayne State University to conduct a study regarding mental health and how interception of those that have mental health issues can be helped. And part of that is with jails, and part of that is to look at, and then through a collection of data through a number of jails in different counties in Michigan, is to look at how the courts can maybe intervene a little bit. Because truthfully, there are some people in my jail that just shouldn't be here. Some of it is protective custody. When somebody decides to hurt themselves or others, or make threats to hurt themselves or others, we have to intervene, and we have to make sure that they remain safe. So part of that is to look at how can the courts assist in intercepting those that may have mental health issues. And so at this time, I'm aware that our courts, the 89th District Court, is looking at the possibility in achieving a grant to set up a mental health court. And I'm for that. I feel that, people who have mental health issues that go out and do criminal acts, once they get the attention they need through medicine and counseling, most of the time they're okay for a while. And the problem is that they relapse. Maybe they decide that they're healthy and they don't need their medicine, or they don't want to go to therapy. I know CMH deals with that, where people feel that they have been healed and don't want to go back to therapy. But the mental health court will say, we want to work with you and we want you to understand what you did is wrong. In order for you to do that, you need to follow a curriculum, and that curriculum will include the help you need, plus maybe to maintain your employment, and this will keep you out of the jail and keep you at home and follow your program. So that part of it's being looked at also in cooperation with the Stepping Up program and CMH. There are other stakeholders involved in that program, because I think the intercept model also looks at even young children, right? Intercept is a key word. We want to intercept the kids before law enforcement has to deal with them, right? So there's a lot of stakeholders. It starts with the parents, and it starts with the professionals, and it starts with the schools. There's a lot of entities that come into play here that need to work together to make this work. So that's what that program is about. But again, from my side, from a jail management perspective, it is lack of beds, because what we find and what I've seen is when people go to treatment, for the most part, they start to be okay for us to deal with. And with that, I'll let Matt talk about how our road patrol handles those situations on the road.
Thank you, Sheriff. I just want to echo everything that Sheriff Cook just said. We experienced the same things here in Emmett County that he's experiencing in Charlevoix. I do want to shift gears here a little bit. So I'm going to talk about a little bit about how we handle situations centered around mental health issues and emergencies from our road patrol perspective. When we say road patrol, that means our boots on the ground, the people that are out on the road. And the first thing that we really want our people to understand is they are not trained to diagnose persons suffering mental illness. However, we try to train them, and we've done training where they recognize that there are people suffering from mental illness, and those can be drawn from observations and a combination of actions. With that, we've instituted policy that guides our people on what to observe and the actions that might be present, and how they should act when they encounter those people that are experiencing mental illness or displaying mental health issues and emergencies. Some of the examples that we instruct them to look for: difficulty communicating, expressing themselves, communication by pointing and gestures, repetition of words, phrases, body movements, little to no eye contact. They laugh or cry for no apparent reason, unresponsiveness to verbal commands, catatonic in nature, self-injurious behavior, and I guess really other behaviors that just aren't appropriate for the existing conditions or circumstances that we might find them in. One of the first things that our policy does is that we guide our staff to de-escalate these encounters with persons experiencing mental health distress. Just like there's things that we ask them to look for, there's things that we ask them to display when they're talking with people at a crisis or experience an emergency. Speak calmly, use non-threatening body language to whatever extent is possible. Eliminate loud sounds, bright lights, anything that's going to be overstimulating. Try to find some personal identification. If you know who the person is that you're dealing with, and quite often that is the case with our people on the road, we are more than likely always dealing with somebody that we've dealt with on numerous occasions. So what we want them to do is contact a person or a caregiver that maybe has a little bit rapport and would be able to help us de-escalate a situation. The next thing we need to do is we need to determine if that person is a threat to themselves or others. After we've identified the crisis and tried to de-escalate, we have to choose the appropriate course of action. So if they're a threat, we have to start looking at a petition. A lot like Sheriff Cook was talking about, our jail is full with, I would say, 60% of people that have some type of mental health issue. It may not be a crisis, but one thing that I don't want to do is I don't want to put more onto my staff. So what we will do is we will petition. And I think that goes along the lines of speaking that we don't really want to put people in jail that are having a mental health issue. There might be an underlying reason there for their actions. And I think it's best to get them the help that they need in lieu of taking them to jail. So when we look at that petition, is the first thing we try to do is ask them to voluntarily go. Kind of goes back to the point that our people are not trained professionals when it comes to recognizing and I guess for better diagnose somebody with a mental health issue. So we would ask them to go voluntarily, and if they won't, then we would take them into protective custody and we would petition for that commitment. When we petition, we always try to, incorporate the family in that. They're going to have more to add into that petition, and it's more than likely that a judge is going to, take a look at that and want to sign that order. One of the questions that was presented to me.
Excuse me, Matt, we've just got 2 more minutes for you guys.
Sure, no problem.
Right.
First question, one of the questions that was presented to me was, do we have access to preventative mental health assistance at the scene? And to my knowledge, we don't, but during the course of this talk tonight, it sounds like, Amy, there is some things that are available to us which we're going to have to take a look at and incorporate that into our policy. One of the questions that's popped up here in our chat here is Emmett County have a mental health court? No, we do not. And that is maybe something we need to take a look at. Because I'm running low on time here. One of the other questions that was brought to me was, what should a bystander do if they encounter somebody whose behavior suggests a behavioral health problem? If you're comfortable contacting that person, by all means do. We would ask that the general public contact 911 and ask for assistance. But again, if you're going to contact that person, I would use the same policy that we use. Maintain some distance, speak calmly, non-threatening body language, eliminate loud sounds, bright lights, other sources of overstimulation. Try to get a hold of somebody that an identified contact person, caregiver. Just really use patience with them. Use repeat short direct phases in the calm, remain alert and attentive to any observable sensory impairments. And then if the bystander feels that they're overwhelmed or in fear, back away and just try to keep track of the person's movements until help can arrive.
Okay, well, I'm muted. No, I'm not. Thank you very much. We're going to turn it over to Dr. McKenna, who's going to tell us about the new services that are available in Sheboygan. And then we'll allow some time for some of these questions to be asked by all of the panelists. Thank you.
Hello, I'm Dr. Matt McKenna, the medical director of the McLaren Northern Michigan Justin Apor Behavioral Health Center. And thank you for this opportunity to speak on this incredibly important issue. Just give you a little bit of background. I've been working as a psychiatrist for close to 20 years, and I've been studying psychology for significantly longer. And over this time, I've been increasingly concerned about how mental health clinicians have been spread thinner and thinner. Recently in Michigan, where I've worked for some time now, and as some of us have already talked about, I've known folks to wait for weeks, if not months, for appropriate placement. There are not enough beds. And even worse, I've known people to stop reaching out for help. It just takes one long wait in the emergency department for them to, maybe the next time they won't try. And it can have real, significant, sometimes fatal consequences. This is added to the longstanding issues of imparity and stigma in behavioral health care. Less than 1/3 of the US population lives in an area where there's enough mental health professionals available to meet the needs of that population. So the Justin Apor Behavioral Health Center is a significant step in addressing this unmet need. One not possible without the incredible generosity of people. Pierre and Renee Bora, the Pulte family, Patrick McDonald, over 400 donors, including the state of Michigan and the people of Sheboygan, have come together to make this possibility. It's incredible. It's been incredible and a privilege to be there from the start and seeing it develop and grow, well, close to the start. And honestly, it's one of the most beautiful psychiatric facilities I've ever seen. I've seen a few in multiple states. And it's been a privilege to work with an excellent team. There's over close to 30 professionals. We can care up to for 16 people at any one time. We offer more than just medication. We offer true psychotherapy and often hope for those in crisis, sometimes at the lowest point of their life. And for people experiencing psychotic disorders, depressive disorders, obsessive compulsive, trauma, substance abuse, personality disorders, and more. And often a combination of these labels. And these diagnoses don't mean as much as people sometimes think they do, because no one person fits any of them so neatly. And I think that's what I found really fulfilling in the work at in Sheboygan is the focus on the person. We serve the community through local emergency departments and hospitals, and we can sometimes get a few from downstate too. And we just opened, so we're not up to the 16 yet, and we can't serve them all right now, but hopefully very soon we'll be completely open. And we aim to grow. We have plans for expansion to a partial hospital program, which I think is very, very important. Hospitalizations, they don't, when I started, they could be for a pretty long time. And sometimes you could write for an order for a weekend pass and have someone who might not be completely ready to be on their own and start exposing them to that environment from which they came. The partial hospital program allows us to do that. So it's for someone who might not need the safety of inpatient care, but still needs close to daily treatment. I think it's a fantastic opportunity. I'm really looking forward to helping out with that. And we do plan eventually to offer treatment for children and adolescents, and that is one of the most painful things to experience, is a family going through a crisis and having really limited options, stuck in an emergency department for weeks sometimes, looking for help. And so I think that more beds will really, really help, and we're on our way to providing some. And working in North Country Community Health is really, through their work in emergency departments and in hospitals, a doorway to us. We hope to continue this relationship and grow.
Well, that's if you're done, we have a number of questions, including some specifically for you, Dr. McKenna. So I might start with those. And actually, this is kind of this might also be something that Ms. Christie can talk about too. There are several people asked about how people in general, people who aren't in a law enforcement related crisis, but have a need for mental health, how they access it, what services are available for people who aren't covered by Medicaid, who maybe have private insurance, and who decides who gets admitted to the New Bora Center. So some of those questions just generally about access for mental health services in our counties.
I mean, I think calling 988 can be a real, it's easy to remember, and it's a real good first step. speaking with a professional can help. At least, if there is crisis, they can help triage and help get the person to care. If their insurance is always, it can be an issue, but I think if someone doesn't have insurance, we have folks who are we're going to work hard to get things paid for so that they can get that help. And it shouldn't be a reason not to reach out, because we'll try to make it work.
Following up with Dr. McKenna, I think one of the things to remember is that through our 24/7 crisis line, or even our access line that rolls to that after hours, whether you have insurance or not and you're in crisis, we will see you. If it's not necessarily a crisis and you still are seeking services, by calling our access line, our staff work with an individual. Yes, they look at insurance and all that, but we also look at medical necessity and acuity. And if we can't provide the services or are unable to provide the services, we will link you with someone in the community that does and that takes the insurance. So it's no wrong door when you call our access number.
Okay, so generally, community mental health access number is a good place for people to start, unless they already have a relationship with a mental health provider.
Yep.
Okay. And so it sounds like even with the new Bora Center, there still aren't enough available beds. Is that correct? And what can be done to remedy that? Is there a solution in sight?
We need more mental health providers. We need more money invested into it. I mean, that's what I mentioned, these donors. I've never seen anything like it. Really putting a whole lot of money with the state together to make this happen. I think this could be a model for multiple places in Michigan and all over the US, because the need is everywhere. But
I could speak just a little bit to that. The state of Michigan has to step up. That just has to happen. When you talk from a jail management perspective, we deal with unimaginable sights and actions of people who are in a mental health crisis, and they need help now. And they can be a security risk until they're stabilized. We need, and I have spoken to our state representatives. I've been in meetings for the last 6 years with Lansing. Not only me, but many sheriffs in northern Michigan, talking about the need for psychiatric beds. And the answer that we get is the money is just not there. I think it's great that we have the behavioral center here that is opening up in Sheboygan County. And like the doctor said, that would not be done without private donations. But to handle what we need in a jail setting, we need the state beds. The health unit that's opening up, they're going to be assisting those that have their mental health issues when they come in. But I'm not so certain as of yet, don't know yet, I'm not so certain as of yet that the involuntary court-ordered people are going to be able to stay at a place like that. And so that's why I think it's real necessary, and I'm being real realistic with this. We have people in our jail that need help and shouldn't be here. So the bottom line is the state has to figure this out with the other stakeholders.
So Dr. McKenna, is the Bora Center available for people who are being involuntarily hospitalized?
Yeah, it is. But typically we can't take folks who are incarcerated.
Okay.
Yeah.
Okay, I have a question here for Amy. What mental health issues do you frequently see in Northern Michigan? Do you feel there are adequate services available for the top 2 to 3 of those?
We currently, any given evening, any given weekend, we're seeing people in crisis after hours, anywhere from 10 to 25 people in a weekend. We're screening throughout the 6 counties. A lot of the issues, and I'm sure the other panelists can concur with this, are mixed mental health and substance use issues. We have to have them medically cleared in the emergency department to figure out, what came first, the chicken or the egg. Is it the substances? Is it the mental health issue? We want to certainly get them the treatment that they want. So we are continuing to try to get our staff, certified as addictions counselors as well, the certification to be able to identify that as well. There's a high level of suicidality, a high level of crisis, high level of isolation and depression. And it's just, again, trying to look at hope and look at services and get the people engaged. A lot of times we get people that come in and then they don't engage after their initial 1 or 2 contacts. So we're really working hard on engaging clients and keeping them in services moving forward.
Okay, So Christine Gebhardt encourages everyone to contact their legislators to support specifically the Mental Health Access Act, HB 4707, which is currently in the House Health Policy Committee. So that sounds like a good specific action that we can take. A question is, if a person is incarcerated and they are already on medication, what is the process for them accessing that medication? Can their family simply bring in what they're already prescribed, or they have to see a provider? And is there a gap in perhaps their access to their medication?
I mean, I can speak for my jail. Their prescriptions are allowed to come in. They go through our medical contractor, and then they're just accounted for to make sure they're what they are, and in consultation with our doctor and our facility, our contractor ACH, and working in concert with their provider. Yeah, we don't have an issue with that at all. Now, narcotics are a different thing. Narcotics have to be justified for them to be passed out in our jail. And if they are justified, then it's a whole different program. So they're by themselves in a sense when that medicine is taken. But yeah, people they can have their own prescriptions. Families can bring them in. They're transferred over to our medical. They're all counted and accounted for, and then they're passed out according to the doctor's orders.
Same with me. In fact, several times we instruct our deputies that, if somebody has medication, bring them with them. It's not going to hurt. Our doctors will clear it. Everything's on the up and up. We have no problem bringing the prescriptions in. And just like Sheriff Cook, same thing here with the narcotics. There has to be a circumstance that would allow it, but yeah, we allow them to bring their prescriptions in. In fact, we encourage it.
Dr. McKenna, are there adolescent beds at the Boris Center?
Not now, no. But it's going to be, it takes some time. Didn't really, there's a lot of hoops to jump through. So even getting this together for adults has taken some time, but I really hope, and that's the plan, to eventually expand and even have a partial hospital program for children and adolescents.
And right now there's 16 beds, but they're not all in use because you aren't staffed for them yet?
We're staffed. It's a process. Right now we've the Joint Commission came by and they approve of everything. We did an excellent job, but it takes some time and some bureaucracy for them to give us the go ahead to really truly open up. So we can only have a few patients now. because they needed to see a few patients for them to evaluate.
And who decides who gets admitted? There's probably going to be more than you can have space for.
Oh, yeah. I mean, so it's there's inclusion and exclusion criteria, but a lot of it will boil down to me. And it's sort of, we take each screening, we have to see if there's anything that you couldn't help them with, but or potentially is too medically complex for the unit. And then we first come, first served, really. And I imagine, though we can't fill right away, because each patient we want to take our time with. We don't want to rush anyone, but eventually we'll be close to full. And that's the thing, I think that, and everyone's speaking of this, just the need for more beds, and it's expensive and it's difficult, but it needs to be done. And I think it does, go back to policy, and as high up as we could go, the state, even nationally, making some real change, because it's otherwise, we'll be continuing to have to make really, really difficult choices instead of having being able to offer everyone, not just the most acute, but some who could still benefit, but they might languish without the intensive services that can be provided by inpatient care.
And are there adequate private outpatient mental health services in our service area? Do any of you can answer that, besides people who are going to access CMH and probably are covered by Medicaid? Are there adequate psychiatrists and other counselors in northern Michigan?
The mental health, the services for folks with who have mental health needs are certainly facing a capacity issue, beyond CMH not having, full staff. There are less and less individuals completing, masters of social worker, masters of counseling programs. So it is becoming somewhat of a crisis, just because we don't have the capacity privately or from the community mental health basis. So we're really trying to think of different ways to bring in interns and utilize students to be able to teach and almost grow our own, so they know the system. So we do try to refer, but there can be wait lists, and psychiatry in the area is very, very thin as well. So I'm glad to see that Dr. McKenna might even be moving up to the northern Michigan area at some point in time, because we're even using fellows. We have a group of fellows every year. We have 4 fellows come and work with us, so that we have more psychiatry and more teaching going on, for the hopes that maybe they'll move to the northern Michigan area and provide services.
Someone reports that there's exactly 1 psychiatrist in northern Michigan who takes private pay outside of the new McLaren Center. The others are in Traverse City. So that's not a lot. Okay. Well, we have reached. Yes, go on.
Well, I was just going to say, I don't know how true it is, but I hear there's only between 200 and 300 psychiatrists that get their degree every year. But even if that's true, I welcome Dr. Matt McKenna to Sheboygan anytime he wants to get up here. So thank you for being part of this, Doctor, and the CMH.
That's great. Well, thank you all for taking the time to participate in this. There are lots of questions, a lot of interest in this topic. I found it very interesting to hear what all of you are doing, especially to keep people out of jail and keep people out of hospitals and get them the care that they need at an early intervention stage. So thank you all. We learned quite a lot, and I'm going to turn it over to Lisa, who's going to bring us to our membership meeting.
Thank you, panelists. If you want to log out, you're certainly welcome to stay for our meeting, but we don't have any more questions for you. So you can get on with your your evening. And members, I hope you'll stay.
Thank you so much.
Thank you. Thanks.
That does conclude our public forum. And Robin has probably stopped the recording or will soon.